My charge is to talk about what solutions we have to restore your cartilage in your knee once we start to lose it. So we're going to talk about some of the classic things that we've had and some of the new enhancements and tricks that we've had over the last few years. And so I think everybody has a good sense of what cartilage is. There are different kinds of cartilage, though. We have fibrocartilage, which is cartilage that's more like your meniscus that we heard about today. It's a little bit more fibrotic. It's a little tougher. It's in the disc in your back. We have elastic cartilage, just like your ear. It's your nose. It's the things that are very flexible. And then we have hyaline cartilage, and those are the what we're going to talk mainly about today, which is the cartilage in your joint. And that hyaline cartilage is made up of chondrocytes. Those are the little cells in your cartilage that do most of the work. They're in a collagen matrix, and it makes this smooth cap over the bone that makes the bone articulate with one side with the other in a very smooth manner. It almost works like a shock absorber in that sense. So cartilage damage, it's funny, I see patients in the office, and I'm like, your knee has a little bit of cartilage damage, a little bit of wear and tear, and the patients are like, thank goodness, I thought you told me I was going to have arthritis. So there is some misunderstanding. When you lose your cartilage, that is arthritis, and it comes, for different reasons. It comes in different varieties. This can be injury mediated. It can be genetically the way you're made, or the cartilage just wears a little bit more. It's not as tough as other people's cartilage. There can be issues with your alignment. Women are made knock-kneed. Men are made a little bit more bow-legged, and that stresses the knee a little bit differently. And then it can just be father time. Over the course of time, things wear. And so what you'll see is that, cartilage wear does come in different varieties. It can come where the cartilage is just a bit thinned, so it's not a significant amount of wear. It can come where it thins and it goes all the way down to bone, and bone is exposed, and then it can even start to wear the bone. So this is healthy cartilage, right? Super smooth. It's a low friction cap. That looks pretty nice. So what we're going to talk about more today is this, where the cartilage is fairly significantly damaged. We see bone exposed. We see cartilage flaps. It's focal, though. It's a small area. And when we look at something like this versus something like this, where there's no cartilage left, right? And our only solution is to replace it. So the things we're going to talk about going forward are the things that keep us away from this and keep us with our own parts. So the real problem, that cartilage damage is very common. So 60% of all the arthroscopic procedures we do will see cartilage damage. And one of the problems is cartilage really doesn't have any nerve supply to it. You can't really feel cartilage. So you can do damage to cartilage in any part of your body, and you really can't feel it a lot of times. You can't feel it till it hits something with a nerve supply like the bone. And then that's where you start to see pain and swelling and dysfunction. And our real problem with cartilage is it really doesn't have a regenerative capacity. There's no blood supply in it. It can't rebuild itself. And then as we age, those cells that we have to make cartilage, they lessen over time. So to restore cartilage, it generally comes in two varieties with regards to the procedures that we have. And so on the right side, we have procedures that really work to make the native cartilage, the native cells in your body, differentiate and proliferate to make cartilage again. And then we're going to have procedures where we actually directly replace that cartilage. And those are the two varieties of procedures that we have available. And what we'll kind of go through is what's our time-tested procedures that we've had, and then what are enhancements now for these procedures. And so really the workhorse of most of our cartilage procedures over time has been microfracture. And this is really trying to stimulate the normal cells that are there. It's trying to, it's really trying to get to the stem cells in the bone. So it makes small holes in the bone. We get the bone marrow that bleeds. It creates a clot, and that clot can form cartilage. The problem is it's not the hyaline cartilage that we want in the joint. It's the stiffer fibrocartilage. This has been, this is kind of the mainstay. It's been done for many, many years. And the short-term results are actually pretty good. The problem is it just doesn't hold up over the course of time. We get 5 years out from these procedures, the results really don't hold up over time. It's an easy procedure to do. It's arthroscopic, and so it's nice in that sense. It just doesn't quite seem to hold up over time. So an enhancement for this procedure is micronized allograft cartilage, which is just donor cartilage that's been basically minced up into a small graft. And this not only has elements of the matrix, but elements of cartilage, and it really works as a scaffolding that you put over the microfracture site. So it's easy against a single step. We can do it arthroscopically, and at least in animal studies, we see that the quality of the cartilage that comes with these is improved. So that's at least one enhancement for a very simple procedure that we have. So then we have our varieties of procedures where we actually replace the damaged or lost cartilage. And we can actually take some of our own cartilage and move it around, and so for an autograft, which is your own tissue, osteochondral transplantation is just taking cartilage from your knee in areas that don't see a lot of stress, in areas of the cartilage that we don't use, and moving those into defects. And as you can see in the bottom side on the right side of the screen, it can be done arthroscopically for small lesions where we move your own cartilage plus a piece of bone. And that really tends to work well. We can use it for slightly bigger lesions if we take multiple pieces of cartilage. And so it's your own tissue, it's real cartilage, it's real bone from you, which tends to work very well. Again, it can be done all in one procedure, which is great. And it looks like, obviously having your own cartilage versus making a fibrocartilage, those results are much better over the course of time. The problem is sometimes in this, we're robbing Peter to pay Paul, so to speak, where we're taking our own tissue and moving it into another area. So there's a size limitation. There's only so much cartilage we can give before we cause a problem. And this is a little bit different and a little bit harder for the kneecap. And it's because that bone is much smaller, it's hard to get a bigger piece of bone into it. So when the defect is a little bit bigger, we can use a graft, right? We have a limitation from our own body's cartilage. We can take a bigger piece from a cadaver. So these are for much larger areas of bone loss. This is a salvage. So we can take a big piece of donated cartilage that you see on the left side of the screen and move it into that larger area of cartilage loss in your knee. So what are our enhancements? So we have a few procedures that haven't been around for that significant amount of time. And we have an option now for cryopreserved osteochondral allograft. So similar to where we would take a cadaver and move that big piece of bone in, now we have the ability to use a smaller piece of this. It's a flexible patch. You'll see the holes that are permeable and porous, and this actually has a tiny little layer of bone on one side of it. So, if you look at the pictures, there's a big defect in the middle of the kneecap. We can still do marrow stimulation there and get some of your own stem cells, but we can actually put a very flexible graft of cartilage with a small amount of bone, and it fits into the defect very well. And the nice thing about this is cryopreserved. There are live cells on it that have chondrogenic growth factors and proteins there to heal. Our other options that we've had available are using juvenile cartilage. So this is a transplantation of cartilage that's less than 12 years old. There are live cells in this, and the thought process is that younger cells obviously have a better potential for growth than even transplanting our own cells, which as we lose that cellularity over time. And this is nice. It's a one-step procedure. You make a putty out of it with fibrin glue, and it fits into the defect there. It's a nice option, although we don't have a lot of data at this point. So one of the other procedures that we've had over the course of time is allograft chondrocyte implantation, or autologous chondrocyte implantation. And this is a procedure that's been done over a long period of time. And it's where we go into your knee, we take your cartilage out, and then we send it up to a lab, and we grow up chondrocytes. And then what you do is we come back and implant that into the defect in the knee. What that requires, though, is you have to have a procedure first for a biopsy, and then we come back and to implant the cells. Over the defect, we have to sew a small patch onto it so that you can inject the cells underneath it and they'll be contained. And that was originally difficult because originally you'd have to take a piece of your own periosteum or the cover of the bone to use that. Over the course of time, that procedure's gotten better. There are some porcine grafts from pigs that you can sew over the top of it to hold the cells in place. And the quality of the cartilage that comes from that is very good, although this is a very, very costly procedure. It's expensive. Sometimes it can overgrow, and it's time-consuming and somewhat of a difficult procedure. So our enhancement for this procedure is a procedure that has just come out. It's been out in Europe for a while, but it's this matrix-induced ACI procedure, which is a similar procedure to what we just talked about. It's the same procedure where you go in arthroscopically, you biopsy a piece of cartilage, we send it to the lab, we grow up cells, but instead of having to take a patch to do that, it's placed on a membrane. So it's a porcine membrane. The nice thing is it can fit any, virtually any size defect. It's a flexible graft. It's something that is much easier to do surgically because it doesn't require suturing and a patch. It just fits into the graft, and it uses your own cells as well. So ideally, we'd like to get to the point where we can scrap all these procedures. And what everybody wants is a miracle stem cell injection, right? We inject the cells in, it remakes our cartilage. And so in areas outside the U.S. that aren't FDA regulated, they're doing a lot of stem cell aspirations and growing those cells up in a lab. The only thing we have available, what you saw in Dr. Sethi's talk, is we're able to take these stem cells out, but we can only concentrate them in that machine, which gives us maybe 60 to 100,000 stem cells of those mesenchymal stem cells that can turn into bone, to cartilage, into tendon. When you grow those up, and in places outside the U.S., they're getting 20 million cells, and what they're doing is injecting those 20 million cells into knees, into hips. Unfortunately, even at this time, what it looks like in that data is that people are getting really good relief of their pain over the course of time. It seems to hold up. It seems that these stem cells, they're a really potent modulator of the inflammatory pathway. But when you look over the course of 4 or 5 years, the improvements in the quality of that cartilage is really only marginal at this point. So we have a lot of options out there, but we still have a lot of work to do going forward. Thank you.